Sure, no, Jen, I appreciate you guys having me, and it's definitely my pleasure to talk to you guys today. And thanks for answering that poll. It does help me cater the slides to kind of the audience. There's a lot of them. I'll try not to be too long-winded, which tends to be a problem for me. So feel free to make comments in addition to asking questions, and I'll try to address both accordingly. My name again is Matt Hudson. Jan, I appreciate the introduction. That was pretty much spot on. Yeah, so I'm with IHS through a program with Johns Hopkins right now, which I'm finishing up in a few weeks. Then I go back to Buffalo. And today, we're going to be talking primarily about non-alcoholic fatty liver disease, or NAFLD, as I'll be referring to it. If there's time, we can draw into some other things like hepatitis C, less so hepatitis B, which doesn't have too much of an association with diabetes to our knowledge, but hepatitis C certainly may, although the jury's still out in terms of the extent of that and how that works. But we're primarily today going to be talking about fatty liver, which is going to be a problem that is seen very frequently no matter where you are in primary care and elsewhere. And it's nice to see that we have a lot of nurses and dietitians, because obviously this is very much an issue of nutrition and obesity. Just to be clear, I have no financial disclosures, and I guess with that we can get started. So again, with non-alcoholic fatty liver disease, what are we talking about here? So the definition that we use in the clinical environment is basically the presence of fatty infiltrates, or a significant amount of fat, or steatosis, in the liver. So it's greater than 5% of steatosis within the liver. And we find that primarily by imaging, which you'll see with your patients typically are they'll have an ultrasound done for another reason, be it abdominal pain, or related to long-standing diabetes, and you want to actually evaluate the liver. But in any event, an ultrasound will be done, and it'll show fat. It'll show steatosis. Sometimes we'll find it incidentally on a biopsy when you're doing a workup for another liver process, be it hepatitis C, alcoholic cirrhosis, etc. But basically, we're talking about fat in the liver. The caveat being you can get fat with other processes. So one of the things and one of the diagnostic criteria is you do have to exclude other causes of fat accumulation. And that includes alcohol, which would probably be the main one to think about. When you drink, you get fat in the liver. That's just what happens. Alcohol is full of calories in addition to the toxins that are produced when you digest or when your body processes the sugars within alcohol. So it causes a lot of fat. So oftentimes you'll have people who drink, but they're also overweight. So then which is which? So you work on the assumption that it may or may not be both. You want to think about alcohol. You want to think about medications, steroids in the context of COPD. If someone's got amiodarone for dysrhythmias, you want to think about such things, tamoxifen for breast cancer prevention, et cetera. But really, the main things you're going to be thinking about are drugs, alcohol, and then fatty liver when you see steatosis or fat on your radiology report from your patients. As far as more definitions go, so NAFLD, non-alcoholic fatty liver disease, is kind of a broad umbrella term. It includes all kinds of fatty liver disease that meet those criteria. And by that I mean NAFL and NASH. So NAFL is just non-alcoholic fatty liver. That's uncomplicated steatosis. There may be some mild inflammation there, but you don't get what we call steatohepatitis, which is kind of, for lack of, to put it in kind of layman's words, some nasty inflammation that leaves scar tissue behind. Whereas NASH is just that. Non-alcoholic steatohepatitis is inflammation that's going to cause long-term damage potentially within the liver. And that damage, we say, is something called ballooning, which ultimately leads to fibrosis. So on the next slide here, we have at the top here, let me see if I can get the arrow. So this section right here is how a healthy liver should look under the microscope. It's nice and uniform. It's pretty dense. There are a couple of spots. These white patches, these white circles, are fat blobs, basically. So this is steatosis, or I should say this is a little bit of fat within the liver. It's less than 5% that's considered normal. But compare that to what we see underneath it. So right here and here, we see 2 liver biopsies that would qualify as NAFLD, or fatty liver. So this is a lot more than 5% of the total area that you see here. But you don't see really any damage. Here you see just steatosis. So these would be macrosteatosis because they're large balloons, basically, of fat or vacuoles. Over here, it's hard to see on the slide, but if you see kind of these bluish or purplish dots, those are white blood cells, so those are some degrees of inflammation within the liver. So you see steatosis with a little bit of inflammation. Now contrast that with the slide over here on the right. This is NASH, so this is non-alcoholic steatohepatitis. So what you see right here where this arrow is and it's blown up over here is basically this is a liver cell, a hepatocyte that's surrounded by fat. So it's kind of floating in a balloon. So that suggests a pretty substantial amount of damage to that hepatocyte. You know, that's living in basically a toxic fatty environment where it's cut off from its blood supply, it's exposed to all kinds of inflammatory mediators. And what happens long term in that circumstance, or often happens, is you get this blue stuff that gets deposited. So this is collagen. This is fibrous tissue. This is scar tissue. That is fibrosis. So scarring, fibrosis, essentially one and the same. There are various degrees of it, so we call it stages. So you call inflammation, you call that a grade. With fibrosis, you say a stage. There's various different staging systems we use. The most common one nowadays, though, is the Preventive system. So I only put this on there for those of you who don't deal with a lot of livers, don't see cirrhosis a lot. So I'm going to be talking about F0 or F2 or F3 or F4 from time to time. And when I do that, just remember that F0, F1 is just little to no scarring. So that's basically a healthy liver, albeit with some fat in it. F2 is when we start getting into kind of the danger zone with NASH, where it's like, okay, this is some significant fibrosis. And then beyond that is where we start really starting to worry. So F3 would be severe fibrosis, and F4 and cirrhosis are one and the same. So cirrhosis is end-stage fibrosis. So kind of beyond the technical or pathological diagnoses, what is NAFLD? So someone basically said in a presentation I went to once that NAFLD is a disease of overnutrition. It's a disease of overeating, basically, or getting too many calories. I don't know if there are any kind of foodies out there, but if anyone's ever had foie gras, basically what foie gras is goose liver that's been, and the goose has been overfed to the point where its liver becomes overtaken by fat. And it's awful to think about that in a patient, but that's essentially the same process. Is if you accumulate too many calories and you basically your nutritional status would be qualified as overnutrition, you develop fat around your organs, what we call visceral fat accumulation, and over time that fat gets to the liver. It is strongly associated as such with obesity and what we call the metabolic syndrome. So 80% or more NASH patients, so this is the extreme form of NAFLD, which we'll talk about, are overweight or obese. Over 3/4 of them have elevated cholesterol levels, so low HDL and elevated triglycerides, likely elevated LDL cholesterol as well. So that's the quote-unquote bad cholesterol, though that's not exactly the right term, but that's why every patient's going to talk to it as. And then roughly 40 to 50% of NASH patients have type 2 diabetes. In those that don't have diabetes, so if you have a patient who comes to you and they have elevated liver enzymes that are modestly elevated, you look at their ultrasound report, it says they have fat in the liver. Even if they don't have diabetes yet, having NAFLD is a strong predictor that you're going to develop diabetes, whether you are obese or not. So even if you're fit or lean, you're more likely to develop diabetes long term if you do have NAFLD. So keep that in mind. It's not necessarily a risk, a definite risk factor, but it definitely is a passenger in the process of pathogenesis of diabetes. Another quote I really like, this comes from a New England Journal article, is it's the hepatic correlate of, or the liver correlate of the metabolic syndrome. So it's very much overnutrition is what we're talking about here. Just as a reminder, the metabolic syndrome is defined as 3 out of these 5 criteria. So it's either a large waist circumference, an elevated fasting blood glucose, elevated triglycerides, low HDL, or an elevated blood pressure. Waist circumference, so I put this on there if you want to refer back to it with the slides. It's going to vary by ethnicity, so it's something to think about. It's not like a one-size-fits-all where BMI is the cutoff. It's actual waist circumference or trunkal or central obesity that we're talking about here. Kind of going a little bit more into depth about what happens. I don't want to go into too much depth because you will forget about it, and there's a lot that we also don't really know. But basically, it all starts with environmental factors. So eating too much, that includes dietary fat, but also excess calories from carbohydrates. Probably some form or some level of genetic predisposition to holding on to that fat, not only kind of throughout the body, but also visceral fat, which is fat surrounding, again, the organs. So there's subcutaneous and visceral fat, and we're talking largely about the latter, although they can travel together. And then, as with all things GI nowadays, everyone's interested in the gut microbiome and how bacteria in our bowels affect these processes. We're in the very early stages of understanding that, but there's likely some role of the gut in terms of fat absorption and cholesterol and fat processing within the liver that predisposes people to hepatic steatosis. But basically, again, we're talking about visceral fat, which in turn leads to insulin resistance, which in turn leads to steatosis. And the classic way to describe NAFLD is a two-step process or two-hit hypothesis, where you get steatosis, you get fat in the liver, but as we'll see, 1 in 4 people in the United States have fat in the liver, and most of them are never going to have a problem. So that would be that fatty liver, that NAFLD, not the NASH, which is where you actually get hepatitis or scarring with it. For whatever reason, in 1 in 5 or 1 in 6 of those people who have fat in the liver, it does become a problem, where you don't just hold on to the fat. That fat, those triglycerides, basically cause the liver cells to get stressed. They cause inflammation to happen. They cause fibrosis, scarring, and over time that fibrosis becomes cirrhosis. There are several different mechanisms that are felt to contribute. So one is our genes. We know that there are at least 2 genes, which I'll talk about one of them because it is relevant in our American Indian and Alaska Native populations, that increase the likelihood that triglycerides will be metabolized to more harmful or more or metabolites that kind of lead to oxidative stress within the liver. We also know, or it's been shown, that certain bacteria within the gut, Bacteroides, Ruminococcus, and some other bacteria, if there's too many of them within the colon or within the small bowel, something called small intestinal bacterial overgrowth, you get elevated levels of both ethanol, so alcohol, but acetaldehyde as well, which is a byproduct of alcohol that actually gets absorbed, goes through the portal vein, which goes up through the liver, and then it has a similar effect to alcohol in the liver. So that is one hypothesis in terms of why it happens in some people and not others. And then there are other thoughts that things like sleep apnea, particularly in patients with obesity, the metabolic syndrome. You get sleep apnea, you sleep without your CPAP machine, you're iffy with your CPAP machine, you get these transient or episodes or short-lived episodes of hypoxia overnight, and that puts oxidative stress within the body and within the liver and causes a reaction within the liver where those triglycerides are more inclined to cause problems as well. It's kind of a simplified explanation, but since things aren't entirely clear in terms of why it happens, it's just a mishmash of a lot of different things. The problem is it's hard for us to predict who are going to have problems with fat in their liver and who are not, and that's one of the things we'll be talking about at least in a bit. So this slide coming in here kind of shows what I was just talking about. So the issues are fat around the organs, gut microbiome, and then some kind of inflammatory mediators that have a genetic component to them, an environmental component to them, all coming together to create stress within the liver. So what about diabetes and NAFLD? Well, as I mentioned, there's a common mechanism for NAFLD, diabetes, and the metabolic syndrome. This is visceral obesity, so it's the common denominator kind of tying them all together. We know that people with NAFLD are more likely to have diabetes. So as far as just benign NAFLD or fatty liver, about a quarter of people with that are going to have diabetes. And when we're talking about NASH, so we know that diabetes itself is a predictor of a worse outcome from fatty liver. So when we're talking about NASH, people who have biopsy-proven not only inflammation, but that ballooning and maybe some of that scar tissue, that's kind of the more severe form of fatty liver, about half of them, or 40 to 50%, are going to have diabetes themselves. So diabetes in that respect is a risk factor for, or has been strongly associated with, a worse course of fatty liver disease. We do know that if you do improve your NAFLD, and we'll talk about how patients can do that, it does reduce your incidence of diabetes as well. So again, they kind of travel together and all work off one another. Additional note is approximately 40 to 50% of people who have diabetes are going to have NAFLD. So, you know, if you're seeing diabetic patients, expect that half of them are probably going to have NAFLD if you were to either check their LFTs, do an ultrasound, or if you were to do a more in-depth kind of non-invasive analysis on them. So this is very relevant to anyone taking care of diabetics, and is certainly a process that you guys need to know about. In terms of why we see diabetes with NAFLD and vice versa, they likely work off one another. So it's not clear if you start with insulin resistance and that causes NAFLD, or you start with NAFLD and it causes insulin resistance. This is kind of probably an oversimplification from my end, but I just wanted to show it's probably a little bit of both. So if you have someone who's got diabetes and has had diabetes for a long time, they have insulin resistance, including peripheral or muscle insulin resistance, that leads to lipolysis, so breakdown of glycogen storage in your muscles and your peripheral tissues. That breakdown of that fat gets taken up by the liver, so the fat gets taken up into the liver by means of triglycerides, HDL, et cetera. And having that there together with that second hit, that oxidative stress, leads to steatosis plus minus, inflammation and scarring. And then we know that that inflammation in the liver itself causes hepatic insulin resistance. And we're kind of going back into this loop here. So you have hepatic insulin resistance. It's going to predispose you to greater lipolysis peripherally, in addition to the underlying diabetes. And again, you get the idea that this is just going in a circle and they're probably feeding off one another. So kind of going back to this slide, you do see here that as your insulin resistance levels increase, this is the amount of, the percentage of fat in your liver also increases. So there is a linear relationship between the two, probably some degree of cause and effect, and probably goes both ways. As far as the epidemiology of NAFLD goes, or the prevalence goes, it's estimated that about 25% or 30% of Americans across all ethnicities have some degree of NAFLD. Now, the majority of that we'll see is going to be just fatty liver without steatohepatitis, so a more mild variant, but it's obviously a very prevalent condition. That's on par with the rest of the world. So overall, about 25% of people throughout the world are going to have it if they're all assessed right now. It's similar to what we see in Europe, similar to what we see in Asia, a little bit lower than what we see in the Middle East, but certainly higher than what we see in Africa, and that probably relates more to a little bit to genetics, but likely also related to environmental factors like nutrition, access to food, size of meals, types of food eaten, et cetera. As I mentioned, about a quarter to a third of people within the United States have fatty liver, which is actually quite astonishing. But relevant to the audience here, between half and maybe two-thirds of diabetics are going to have some degree of fatty liver. And among obese patients, you're probably looking at the higher end of that, so two-thirds, maybe 75% in the limited literature that we have. There's not a huge prevalence study, but NHANES suggested about a half to two-thirds of obese patients have some degree of fatty liver. And again, 40 to 5, maybe 50% of diabetics. People who are morbidly obese undergoing bariatric surgery, so that's gastric bypass, sleeve gastrectomy, greater than 90% of them are going to have fatty liver at the time of their surgery. So this slide kind of breaks down how this is a public health crisis in the United States. So again, about 25% of adults in the United States are going to have fatty liver of all kinds, so NAFLD, that umbrella term. Of those, about 5% are going to have NASH. So about 1 in 5 people with fatty liver are going to have a more severe variant. And of that 5%, then approximately 1/5 of that, or about 2% of Americans, are going to at some point have NASH cirrhosis. When you think about the size of the United States, we're basically saying that 1 in 50 U.S. adults are going to have cirrhosis at some point from NASH. That is incredible. And I'm working primarily with NIHS on hepatitis C work, among other things. But once hepatitis C gets tackled within NIHS and just throughout the United States and world in general, now that we have great medications for it, the #1 transplant indication is by far going to be obesity, overeating, larger meals, poor nutrition, malnutrition in the overfed state. That's just extraordinary. And when you do have NASH cirrhosis, your risk of getting hepatocellular cancer is about 1 to 2% per year. So this is an understated and really quiet epidemic that most people, providers underestimate, but certainly the general public doesn't really appreciate. I have seen so many people get diagnosed with cirrhosis, have diagnosed people with cirrhosis who have never had a drink in their life, who are like, I can't have cirrhosis, I didn't drink. And it's a grandmother of 3 or 4 who's 70 years old but has been carrying extra weight her whole life and has been eating an American diet, and everyone's just kind of floored by the news for no other reason than most people don't know this can actually happen. Within American Indian and Alaska Native populations, we don't really have a lot of great data. So this is pretty much what's out there. This comes from a combination of 2 studies from the early 2000s. About 4 to 7% of American Indian and Alaska Native populations are going to have some degree of chronic liver disease. Much like most ethnicities in the United States, alcohol, hepatitis C, combination of the 2 are going to be the main culprits here. But you see over here we have NAFLD kind of contributing in the lower 48, in the western United States, of somewhere around 12 to 15% of patients in the early 2000s. In Alaska, it was about 30%. That number in both regions has probably increased just because trends in obesity and diabetes have increased over the past decade as well, or 15 years. So I would suspect those numbers are probably closer to that of the general population, which again is around 25%. And why do I say that? Well, as with many populations, obesity is a problem in American Indian and Alaska Native populations. Here's a study that the CDC did in 2010, which shows that obesity is a big problem within American Indian communities. And also, diabetes is an issue. So diabetes is the 4th leading cause of death throughout the United States. In American Indian and Alaska Native populations, it's the #1 cause, last I checked. Obviously heart disease is a factor as well. So you can see here that obesity, diabetes, hypertension, presumably if we're talking heart disease, and atherosclerosis, dyslipidemia, so metabolic syndrome in general is very much an issue that's relevant to American Indian and Alaska Native populations. And to add to that, too, is there is a genetic predisposition to getting fatty liver in our population. So there is a mouthful called patatin-like phospholipase domain-containing protein 3, or PNPLA3. It's a gene that makes a protein called adiponutrin, which is involved in the regulation of triglycerides, retinols, basically the breakdown and metabolism of triglycerides in the liver. And there is a polymorphism, or a change in this gene, that is most prevalent among Hispanic populations who are most at risk for NASH and NASH cirrhosis, but it's also very prevalent in Asian and American Indian and Alaska Native populations. So there's a strong association with this polymorphism with steatosis, fat in the liver, but also with the more extreme forms, steatohepatitis, fibrosis, and then liver cancer. So it's again, very relevant in the Native American communities. This also kind of contributes to negative effects of alcohol and hepatitis C in Hispanics, Asians, and American Indian populations as well. So it's relevant not only in NAFLD, but other forms of liver disease as well. So what's the big deal? Who cares about NAFLD? If everybody's got it, why do we care about it? I say that somewhat facetiously, but it's a big deal. And one of the reasons it's a big deal is if you have innocent NAFLD, which is to say if you have just steatosis, just fatty liver, but no ballooning, no fibrosis, your overall mortality is not going to be much more increased than the general population. So when we're talking about fatty liver, quote unquote, without NASH, you're going to die, or your patients are going to die, just like everyone else, from cardiovascular disease, from cancer. That mortality basically is similar to someone who does not have NAFLD. But when you're talking about NASH, when you have that predisposition, that second hit for whatever reason, genetics, environmental, etc., your mortality is going to be 2.5 that of people who don't have NASH, so 2.5 times everyone else. So in addition to cardiovascular disease, cancer, the other things that we see with metabolic syndrome, with diabetes, etc., we're going to also have to worry about liver-related issues. So not only cirrhosis, but what kills you with cirrhosis, so liver failure, hepatocellular carcinoma, bleeding varices, etc., infections. So the liver-specific mortality in patients with NASH is, it's markedly increased. It's 64 times that of people who don't have NASH, who don't have other comorbidities associated with drinking, or with liver disease. We saw this before. Again, NAFLD, just to again reiterate this point, less likely to become cirrhosis. Most of that 25% aren't going to have a problem. Those with NASH may very well progress to cirrhosis. So it's going to be about a quarter of people with NASH are going to have fibrosis that advances over time. The risk for a worse outcome with NASH, look at that, diabetes and insulin resistance. So, certainly relevant in the population we take care of. Other things you think about, hypertension, so another component of the metabolic syndrome, obesity or recent weight gains, and then LFT elevations. Just to kind of break it down, if you have a patient who has F2 fibrosis from NASH, it's going to take about 10 years for that to progress to the next stage. So if you have F1 or F2 fibrosis, it's going to take you 10 years to become F3, 10 years to become F4. So if you get diabetes at 25 or 30 years old, and then 10 years later, let's say around 40, you go see your provider or you have your patients and you do an ultrasound on them knowing they've had diabetes for a long time, looking at them for NAFLD, and you run through everything that we're going to be talking about. They have F2 fibrosis. If they don't change their ways, which is to say lifestyle modifications plus minus some medications, they're going to progress to cirrhosis in about 20 years. So that 40-year-old at 60 is going to have to start really worrying about what's going on with the liver in terms of liver cancer risk, et cetera. And we see NAFLD in children as well. Obviously, obesity is an epidemic among youngsters in the U.S. It is strongly associated with childhood obesity. A study out of Denmark showed that obese children there had an increased risk of hepatocellular carcinoma into adulthood. So I'm not a pediatrician, but if you do take care of children, we need to start thinking about fatty liver in them as well. So how do we diagnose it? Well, there's two things I want you to think about. Diagnosing NAFLD, not the end of it. So you're going to find steatosis, fat in a lot of ultrasounds. You're going to see elevated LFTs in patients who have diabetes or metabolic syndrome. But you want to be able to distinguish who's got, who you should be worried about. Who are that 25% of the people with fatty liver who are going to progress to something bad, and who are people that you kind of sit back and say, well, lose some weight, change your diet, we'll keep an eye on things. So hopefully you can get that out of this, and hopefully I don't confuse people too much. Your typical situation, though, is you're going to draw LFT or transaminases. This is part of your LFT panel. your AST and your ALT are going to be mildly elevated, particularly the ALT because it's an ALT-driven process predominantly. You end up doing an ultrasound because you see these LFT elevations, and it shows fat in the liver. And then you check for other causes of the LFTs being elevated, so viral hepatitis, autoimmune disease, iron studies, alcohol, etc. Now what do you do? So in this person, you're going to think NAFLD. You're basically going to think NAFLD in everybody. As we already said, a quarter of U.S. adults have it. Higher numbers of diabetics have it. You're also going to think, hey, might this be a more substantial form of NAFLD, like NASH, if there are risk factors for it? So you're going to think about NAFLD in diabetics. So as I already mentioned, 45 to 50% of diabetics have NAFLD. But also, if you don't have diabetes and you have NAFLD, as I mentioned, you're going to be more likely to develop diabetes. So if you took people who had NAFLD and who don't, the people who have NAFLD are twice as likely or have twice the odds of having diabetes than those that don't. And if you take people who don't have diabetes and you take people who have NAFLD who don't have diabetes and people who don't have NAFLD who have diabetes and you follow them over 3 years, the odds of the people who have NAFLD but no diabetes developing diabetes in that 3-year period is almost twice as high as that of people who do not have NAFLD. So again, this is something in your pre-diabetics especially you're going to start worrying about, because if you see steatosis in them, they're going to be at high risk for further progression of their diabetes in addition to potentially their liver disease. And then who do you think about in terms of, all right, who's going to be a problem child as far as their fatty liver goes? Who do I really need to be worrying about? If 3/4 of people are going to do just fine and I need to worry about, their cholesterol, their A1C, et cetera, who do I need to think about? Oh, what about their liver too? Here you can see, age, male gender, BMI, obesity are all factored into it. But look, so is diabetes. So diabetics, if you took all people with NASH fibrosis, they're going to have, the odds of them having diabetes are going to be 4 times that of people who don't have NASH fibrosis, who just have kind of fatty liver disease. So having diabetes is in and of itself a risk factor for having a more aggressive course of fatty liver disease, as is having metabolic syndrome. So again, truncal obesity, elevated blood sugars, elevated cholesterol, hypertension. These are all, when you go back to this, risk factors for developing NASH fibrosis. So basically, anyone with metabolic syndrome and many people with diabetes, you're going to worry about what's going to happen to their liver in the long term. That said, though, you do want to still think about NAFLD in everybody. So if you have lean patients as well, there is a phenotype or subgroup of patients who are lean, but they still can get fatty liver disease. And other additional risk factors for that in this lean category, smokers, older age, Hispanics, Asians, possibly American Indians and Alaska Natives as well. And again, this is a problem of excess caloric consumption. If you're thin but you eat a ton and your diet's terrible, and you have you're a smoker, you may still be at risk for NAFLD, for fatty liver, even if you don't kind of physically or phenotypically show yourself as being obese. All it takes is a modest, 3 to 5 kilogram weight gain to predict the development of NAFLD from, a baseline or what is a healthy BMI for you. So it doesn't take much to put you at risk. I read this as I was preparing this talk. It's a great little statement. Overweight or obese patients with metabolic syndrome, elevated LFTs, and negative non-invasive workup for other causes are likely to have NASH. So again, keep that in mind. So once you diagnose someone with NAFLD, now what do you do? So you're going to basically look for confounding risk factors for your disease progression. You're going to look to see if there's any evidence of liver damage that should make you worry more, should make you think, should I get a liver biopsy or not? You're going to grade the severity of this damage, like I said, by biopsy or non-invasive means, and then you're going to formulate a disease plan. Since I think our audience is predominantly dietitians and nurses, among others, I'm going to try not to delve too much into the nitty-gritty of when to biopsy. Certainly, if there's more, I'd rather talk about how to treat NAFLD, because that may be what you are more than likely to be involved in. But certainly, if you have questions, please ask, or if I'm skipping over something too quickly, let me know. So again, once you suspect NAFLD, you're going to do a pretty intense history and exam related to it. You're going to look for associated conditions, hypopituitarism, A-beta lipoproteinemias, all these like kind of zebras that are out there. You're going to look at their meds, see if there's anything you can implicate or remove that might be contributing. You're going to do an audit of their alcohol use. Again, the audit questionnaire, which I'll show up here and will be one of the slides, I prefer to cage just because it takes better into account, excess alcohol use rather than alcohol abuse. And I think excess alcohol is more the issue than purely is there alcohol abuse or substantial alcohol dependence going on. That's obviously a problem you want to address as well. And then on exam, you're going to look at things like truncal obesity, acanthosis nigricans, which can be associated with a more aggressive form of NAFLD, associated with NASH, associated with metabolic syndrome. You also want to look for evidence of portal hypertension. So again, you're looking for evidence of cirrhosis here. If you're not great at measuring liver spans, the more obvious things you're looking for are going to be icterus or jaundice, a yellowing of the eyes, skin, gynecomastia, so increased breast tissue. These are spider telangiectasias. Look at the chest of the patient you're worried about and see if you have these little telangiectasias, because they're a pretty good surrogate of underlying portal hypertension, liver disease, and obviously ascites at this point. Cat's out of the bag, and it should be pretty obvious that they have liver disease. So once you suspect NAFLD, what you're going to do is you're going to order these wet biomarkers, albumin, prothrombin, platelets. Those are your true liver function tests. But you're also going to look at your transaminases. So as I mentioned, NAFLD's an ALT-driven process. You're going to look at the AST to ALT ratio. Should be less than 1. If it's greater than 1, that's a problem. So with alcohol, we see a classic 2-to-1 ratio. That shouldn't be there with NASH or NAFLD. If it is there, that would suggest that they're going from NAFLD or NASH with no fibrosis to the F2, F3, F4 fibrosis. So this should really start making you worry for clinicians who are listening in, and you're looking at the liver panel of your patients who you think have innocent fatty liver. This is the problem. So if you have a non-drinker whose AST to ALT is 2, and you suspect they have NAFLD, you want to do a more intensive workup. You're going to look at iron studies as well. Those are going to be very nonspecific. When you get all this together, I prefer using the NAFLD fibrosis score. It's an online calculator. You just go online to University of Washington or MD Calc or any of those free online calculators, and you can calculate a NAFLD fibrosis score. This will tell you if it's below negative 1.45, it is very unlikely that they have fibrosis. Even if they have NASH, they probably don't have fibrosis. And this is probably someone who's going to do just fine. This is probably someone who just has innocent fatty liver and is never going to have a problem, and you're going to want to address their cholesterol, their diabetes. You want to encourage them to lose weight, but you're not going to be as intense about screening for cirrhosis or fibrosis. If you go higher than that, though, to the indeterminate range or even higher, you need to act on it. But this would be the step, especially if you're in a more remote spot where it's not easy to refer to a hepatologist or a gastroenterologist. You can do this in the office. You can do this for free using a calculator, and it can put you and your patient at peace of mind if you end up with this low number. You can probably manage that on your own without a liver biopsy. But if you start getting anything higher than this, you want to think about biopsy. You want to think about referrals. FIB-4 is also good. I like NAFLD fibrosis score because it does take into account things like hyperglycemia, BMI, factors related to the metabolic syndrome. Skip over that. Again, here is a slide just talking about who you should refer for either a liver biopsy or for a fiber scan. So vibration-controlled transient elastography is a type of ultrasound machine now we use. It uses sound waves that bounce through the liver. Premise is if the liver is scarred, it's solid, it's going to pass through faster than if it's like a more amorphous, kind of liquidy, normal tissue kind of blob. Again, if there's no metabolic syndrome, if there's no diabetes, normal LFTs, you have a motivated patient who's going to lose weight, you got a low fibrosis score, you don't really need to refer that guy or gal for extra testing. You should just, talk about losing weight, which we'll talk about, et cetera. If you might want to consider doing a fiber scan if it's available in your clinic or near you, but if it's hours away, it's probably something that can be deferred. You do want to refer someone for a fiber scan and or a liver biopsy if your NAFLD fibrosis score starts creeping up, or they have risk factors like the metabolic syndrome, or if they have diabetes and their LFTs are going up and they're not getting better with some weight change interventions. There's no great algorithm, So again, here are some risk factors for a more aggressive course that you want to think about. But again, no AASLD or none of the other liver societies have an algorithm to follow. That said, everyone always throws out algorithms, so I did include them in your presentation, so if you want to refer to them. But again, if you have a low fibrosis score, low likelihood of having fibrosis, you can kind of follow this in primary care with simple management. If it starts creeping up, you want to think about doing a FibroScan referral or performing a liver biopsy. There are caveats, though. If someone's morbidly obese, diabetes, their LFTs are up, you might be a little bit more worried. Even if their NAFLD fibrosis score is on the low side, you might jump them into this category where you send them for a FibroScan. All right, another one, kind of moving along here. So once you are concerned about NASH, liver biopsy is the gold standard, but nowadays we generally recommend doing transient electrography. That's that vibration pulse ultrasound to determine whether or not there is fibrosis. There is also something called magnetic elastography. It's an MRE. It's an MRI that basically does a similar thing to the FibroScan device, but is the MRI equivalent of it, where it basically sends a sound wave through the liver. It generates a wave propagation image and turns this into an elastogram. This will tell you like how much scarring is there. And it's actually very accurate and has a good, so here you can see the area under a curve here is great for FibroScan. The MRE is even better. But again, this is a test that's it's not available it's hard for me to get in Buffalo, which isn't a big city, granted, so it's even harder if you're in a more remote area, I suppose. I think we covered that as much as I want to, but certainly we can talk a little bit more about this. Let's move on to treating NAFLD. So again, your treatment should address the liver disease if it's NASH, but the majority we're going to be talking about is addressing the underlying metabolic comorbidities. So primarily the obesity, but also the hyperlipidemia, the diabetes, et cetera. Most people with NAFLD are never going to have a problem from it, so this is the priority for them. People who do have fibrosis are still going to have these things as problems in addition to managing the liver disease. So lifestyle interventions, so I know there's a lot of dietitians listening. This is where you guys are leading the charge. This is really, you are what these folks need. Weight loss is the cornerstone of treatment of NAFLD, and as a physician, I can tell you that doctors are terrible at getting patients to lose weight. So that's why for those of you who are nutritionists, dietitians, I mean, you guys are the saving grace for this epidemic. So weight loss is the cornerstone of NAFLD. What you want to do is exclude processed foods, fructose, but the magic number is 7%. You want to achieve a 7% weight loss from your baseline weight at which your NAFLD is diagnosed, your patient's NAFLD is diagnosed. And that has been shown to be the saving grace in terms of reducing the progression of steatohepatitis in patients. When you lose that 7%, it improves your clinical markers like AST, ALT, but also improves the steatohepatitis on biopsies and may improve the fibrosis of the scar tissue. Alongside that, though, I'm a big advocate of Mediterranean diet for these patients, only because there's pretty good data out there about how it plays into both insulin resistance, but also in fatty liver itself. I also think it's easier for people to follow, because you can get a solid Mediterranean cookbook or go online, and I feel like it's permissive of carbohydrates. If you say, oh, low carbohydrate diet, there are permitted carbohydrates within the Mediterranean diet that are easier for people to wrap their brain around, in addition to stressing things like fish and avoiding sort of red meat, etc. Using a Mediterranean diet, regardless of weight loss, also reduces steatosis and improves insulin sensitivity and glucose tolerance, so that is very relevant in diabetic patients. As far as weight loss goes, this is the study that best shows that weight loss helps in NAFLD and NASH, done out of Brown by one of my old professors, Kitty Chak Promrat. It's been reproduced, which we'll see. but it's a really, really intense weight loss regimen. So bi-weekly or weekly group meetings, calorie goals of 1,000 to 1,200 kilocalories if you're less than 200 pounds, 1,200 to 1,500 if you're more than 200 pounds. Daily fat goals, meal plans provided, including Jenny Craig's, Nutrisystems, etc. Focusing on walking, and then doing self-monitoring. So they really, really were regularly in touch with patients, and they all, or a lot of them, lost weight to a significant degree. So most lost close to 10% of their body weight, and obviously had a concomitant BMI reduction. But it did show resolution of the steatohepatitis in a fair number, or marked improvement. Didn't show improvement of the fibrosis, but once you're scarred, you're scarred. There might be a modest improvement, but in general, what you're looking to do is reduce further the risk of further scarring or further progression of fibrosis, and that's what losing 7% of the body weight did in this case. It was reproduced in a European study where, trust me going through this because we were short on time, but these are people who had improvement of their steatohepatitis, their fat in their liver, local inflammation, ballooning, and this is all in the 5 to 7% range. So, you're not even asking people to lose a specific number of pounds, because everyone's going to come to you at a different weight, but you want to take that weight and you want to reduce it by 5 to 7%. 0.5 to 1 kilograms per week or two is a good way to go. Mediterranean diet has been shown to reduce your level of insulin resistance and improve insulin sensitivity, as you see over here. Here's a nice guide for the Mediterranean diet that you can print out and send to patients. Link to it is down here. Similarly, in a different study looking at the Mediterranean diet, it was comparable to a low-carbohydrate diet in terms of weight change and weight loss. But what's particularly cool in diabetics about it is, looky here, you have a reduction in your insulin resistance that is better than a low-fat and better than a low-carbohydrate diet. And in non-diabetics, something that's comparable to a low-fat diet. So, certainly in a diabetic patient, a Mediterranean diet is a good option, I would say. And it is probably a good option in every person, even if it's not, even if you don't have the insulin markers to reflect it in non-diabetics. Bariatric surgery is another option to help with weight loss. So, you see marked resolution in NASH. Here we have what 88% of people had, had mild to moderate NASH on biopsy. Then they had their bariatric surgery, and 85% of them had no NASH thereafter. So that's pretty impressive. So that is an option for patients, and is certainly a treatment to address NAFLD and NASH. Alcohol should always be done in moderation. If you have fatty liver, having drinks every once in a while is okay. I tell patients, if you want to relax and, go to a picnic and have a wine or a beer or two, that's okay. Remember, I mentioned be drinking more than, 2 drinks per day. Any more than that, 3 or 4 is going to cause problems in the liver. Women, it's probably more like 1 to 2 drinks per day. If someone has NASH, though, or someone has fibrosis on a biopsy, I generally recommend they abstain from alcohol altogether. During the workup process, I usually recommend avoiding alcohol just because it can drive up the LFTs and it can kind of throw off responses to things like weight loss, etc. Other recommendations: increase physical activity with walking, smoking cessation, possibly coffee. You need to drink 2 or 3 cups of coffee a day to potentially reduce your risk of NASH fibrosis, but this is one of those things that changes every other month, so not clear. In terms of drugs, not used in most cases. We reserve pharmacotherapy only for people who have NASH with advanced fibrosis, and for people who don't have advanced fibrosis or don't have a biopsy who can't meet their lifestyle goals. We're talking about the glitazone. So pioglitazone, for one, has been shown to lead to improvements in NASH. Vitamin E has also been shown, and it's kind of the mainstay for treatment. That said, though, in most people, you don't really need to start these because most people should respond to weight loss and lifestyle interventions. This just proves or shows the Pivens trial, which is the study that showed a statistical benefit to starting vitamin E in patients who had NAFLD, and also for starting pioglitazone. Pioglitazone didn't meet their primary endpoint, but it met all their secondary endpoints, so it kind of got pushed to the wayside in terms of its initial recommendation as a therapy, but it's certainly something that could be considered in someone who has NASH with fibrosis. Certainly if they're a diabetic, cool. If they're a non-diabetic, something like vitamin E might have more appeal just because you tend to gain much more weight with pioglitazone. One of the things with vitamin E, it sounds benign. It probably is nowhere near as concerning as far as increased risk of an adverse outcome as it's said to. But there is some older literature that's poorly done and not good studies with, where they didn't control for gender, where they didn't control for comorbidities, where vitamin E led to, high doses of vitamin E led to an increase in cardiovascular mortality. More recent studies don't show this association, but generally we still reserve vitamin E for patients who have NAFLD or NASH with fibrosis who aren't responding to lifestyle interventions. We usually use about 400 international units per day rather than the 800. Don't use it in folks. I don't use it in men with prostate cancer history or family history just because there has been one study that showed an increase in prostate cancer risk with using vitamin E long term. So just to kind of ram this point home, we're not thinking about pharmacotherapy because I know we're short on time. You do want to address cardiovascular risks. So the number one killer of the overwhelming majority of people who have fatty liver disease is going to be cardiovascular disease. So please use statins in patients. Having elevated LFTs is never a contraindication to using a statin. There has never been shown to be a adverse outcome or a proven risk of using statins in people with liver disease. There's never been shown to be a consistent cause of death, liver-related death in people from statins. If anything, statins in someone who has elevated LFTs will likely cause them to improve, as shown by the Greece trial on the left and another trial on the right, because more often than not, the elevated LFTs are going to be related to NASH and NAFLD, and these statins can actually help with the lipid profile. There is a question from Al about accuracy of FibroScan results in obese patients. There is a probe called the XL probe, which has a comparable sensitivity and specificity to the M probe in people who are obese and morbidly obese. So if you do send someone for a FibroScan, you want to request that they use the XL probe. You want to be a little bit suspicious if they use the M probe. The other thing you could do is use the MRE if you have access to a radiologist or a radiology group who have that software. It's not hard to get. You just need to get the software. It's just a lot of places don't want to pay for it, but that can overcome that. If you have ascites, you don't need to do a FibroScan because you have cirrhosis at that point. So I would not recommend a FibroScan in someone who has clinical cirrhosis. At that point, refer them to a hepatologist. If you calculate a MELD score, which we'll talk, well, we have a minute left, you should refer them to a transplant center. We don't use GLP-1 meds to treat NASH or NAFLD. Certainly if you're going to use them in diabetes, you should continue to use them in diabetes. Going back. Oops. We have a possible improvement of steatohepatitis in the literature, but it's never been shown to have a consistent benefit. There's no contraindication to using them for this, like if you're going to use them in a diabetic, but I wouldn't use them as a primary treatment for NAFLD or NASH. I think we covered just about everything, but one of the things I do want you to notice and note is if someone's got cirrhosis, like we were just talking about, they should be referred to a hepatologist. They should, if they have a MELD score of 10 or higher, they should be referred to a liver transplant center. And if they have cirrhosis, don't forget their increased risk for hepatocellular carcinoma, so an ultrasound every 6 months, plus minus an AFP, alpha-fetoprotein. You want to do varices screening if you have access to someone who can do a scope. If not, you can look at their platelet score. Or if they don't have ascites and you want to do a FibroScan, you can use a cutoff of 20 on the FibroScan to determine if they might have a risk of upper GI bleeding from their varices. Last but not least, monitoring. If they just have NAFLD or NASH without advanced fibrosis, I usually check serum aminotransferases, so AST, ALT every 3 to 6 months.